Stroke facts. Why we say time is brain. Stroke is a leading cause of serious, long-term disability among adults in the United States. It ranks as the fifth leading cause of death nationally, but its impact is even greater on a global scale. Stroke is the second leading cause of death worldwide. Within Los Angeles County, it also holds the position of the second leading cause of death. Each year, approximately 140,000 Americans die from stroke, and roughly 795,000 people experience a new stroke. Currently, about 5 million stroke survivors are living in the United States, and the lifetime risk is staggering. 1 in 6 people will have a stroke at some point in their lives. The reason doctors and public health officials emphasize acting quickly is simple. The brain loses function at an alarming rate once a stroke begins. In a typical acute ischemic stroke, every minute matters. With each passing minute, the brain loses approximately 1.9 million neurons, 14 billion synapses, and 12 kilometers, or 7.5 miles, of myelinated nerve fibers. That is why the phrase, time is brain, has become a core principle of stroke care. The sooner treatment restores blood flow, the more brain tissue is saved, and the better the chances of recovery. Human cost of stroke, the heavy toll on lives. The devastation of stroke extends far beyond the initial event. Within 6 months of having a stroke, nearly 1 in 3 people will die. For those who survive, the long-term burden is profound. Among long-term survivors, about 1 in 3 requires daily assistance from a caregiver. 1 in 5 needs help just to walk. Roughly 1 in 6 ends up living permanently in a nursing home. And the vast majority, 71%, are unable to return to work, facing lasting impairment that changes their livelihoods and independence. Disabilities just 2 weeks after stroke, what survivors face. Even in the short term, the disabilities following a stroke are overwhelming. At just 2 weeks after the event, the majority of survivors experience severe physical and emotional challenges. Weakness on one side of the body affects 70 to 85% of patients. Trouble walking impacts 70 to 80%. Speaking difficulties, including finding words or forming sentences, occur in 20 to 35% of cases. Vision loss affects about 1 in 5 survivors. Depression, a common but often overlooked consequence, strikes 40% of patients. Most strikingly, 50 to 85% of stroke survivors need help with basic activities of daily living, such as bathing, dressing, eating, or using the toilet. These numbers paint a stark picture of why better treatments, including nerve repair strategies, are so urgently needed. Stroke risk increases with multiple risk factors, and the most effective way to decrease the burden of stroke is prevention and patient teaching. Non-modifiable risk factors include age, with stroke risk doubling each decade after age 55, gender, as stroke is more common in men but more women die from it, ethnicity and race, with higher incidence and death rates in African Americans, and heredity or family history. Modifiable risk factors include hypertension, heart disease, diabetes, serum cholesterol abnormalities, smoking, obesity, sleep apnea, metabolic syndrome, lack of physical exercise, poor diet, and drug and alcohol use. Addressing these modifiable risks through lifestyle changes and medical management is key to reducing stroke incidence. Ischemic stroke, risk factors, and pathogenesis. Key risk factors for ischemic stroke include hypertension, diabetes, smoking, atrial fibrillation, mechanical heart valves, and patent foramen ovale. The pathogenesis begins with decreased perfusion, which leads to anaerobic metabolism. This triggers glutamate release, followed by calcium influx, ultimately resulting in infarction and necrosis. Ischemia can arise from several mechanisms: thrombosis, clot obstruction due to an atherosclerotic plaque; embolism, commonly causing large vessel infarctions, often from atrial fibrillation; hypoperfusion, shock, typically affecting watershed areas; or cerebral venous sinus thrombosis. The vessels involved may be large arteries, such as the middle cerebral artery, MCA, anterior cerebral artery, ACA, or posterior cerebral artery, PCA. Alternatively, small, deep penetrating arteries may be affected. For example, the lenticulostriate branches of the MCA, thalamoperforators of the PCA, or paramedian branches of the basilar artery. These small vessels supply the basal ganglia, thalamus, internal capsule, and brainstem. Brain lobe lesions. Frontal lobe lesions produce disinhibition and impairment of judgment, a magnetic gait, and a deviation toward the side of the lesion. Parietal lobe lesions differ by hemisphere. In the dominant hemisphere, usually left, Gerstmann syndrome occurs, characterized by agraphia, acalculia, finger agnosia, and right-left confusion. In the non-dominant hemisphere, usually right, the result is contralateral hemineglect, distortion of perceived space, and extinction. Temporal lobe lesions affecting the superior region, Wernicke's area, cause Wernicke's aphasia and right superior quadrantenopsia. If limbic structures are involved, e.g., the amygdala, there may be behavioral changes such as fear. Bilateral temporal lesions are seen in herpes simplex virus encephalitis, and bilateral amygdala lesions produce Kluver-Bucy syndrome. Occipital lobe lesions result in homonymous hemianopsia with possible macular sparing, as well as visual hallucinations. Large vessel occlusion and stroke features. Occlusion of the anterior cerebral artery produces a distinctive set of features including confusion, weakness, and numbness on the affected side, especially involving the leg, incontinence, loss of coordination, impaired motor and sensory functions, and personality changes. Occlusion of the middle cerebral artery results in aphasia when the dominant hemisphere, usually left, is affected, dysphagia, homonymous hemianopia on the affected side, hemiparesis on the affected side, with face and arm more severely involved than the leg, decreased sensation on the affected side, and neglect, typically with right-sided lesions. The common carotid artery bifurcates into the external carotid artery, supplying the face and neck, and the internal carotid artery. The internal carotid artery gives rise to the anterior cerebral artery, ACA, and the middle cerebral artery, MCA, which together supply the anterior circulation of the brain. In carotid artery stroke, features include weakness, paralysis, numbness, sensory changes, visual disturbances on the affected side, altered level of consciousness, bruits, headaches, aphasia, and ptosis. In posterior circulation stroke involving the vertebrobasilar artery, features include weakness and decreased sensation on the affected side or contralaterally, numbness around the lips and mouth, visual field cuts, diplopia, poor coordination, dysphagia, difficult articulation of speech, dizziness, amnesia, ataxia, tinnitus, and nausea with vomiting. The posterior cerebral artery, PCA, arises from the basilar artery, part of the vertebrobasilar or posterior circulation, not from the internal carotid. Occlusion of the posterior cerebral artery leads to sensory impairment, visual field cuts, blindness, dyslexia, coma, memory loss. If the medial temporal lobe is involved, thalamic pain, and usually paralysis is absent. Right brain versus left brain damage. A stroke on the right side of the brain produces right brain damage. This results in paralysis on the left side, hemiplegia, left-sided neglect, and spatial perceptual deficits. Patients tend to deny or minimize their problems. They often demonstrate rapid performance with a short attention span, appear impulsive with safety problems, and have impaired judgment as well as impaired time concepts. In contrast, a stroke on the left side of the brain causes left brain damage. This leads to paralysis on the right side, hemiplegia, impaired speech and language, aphasias, and impaired right/left discrimination. Patients tend to be slow and cautious in performance. They are often aware of their deficits, leading to depression and anxiety. Comprehension related to language and math is also impaired. Small vessels occlusion. Small vessel occlusion leads to lacunar infarcts, which are small, deep infarcts, less than 1.5 centimeters, caused by occlusion of a single small penetrating artery. The mechanism is often related to hypertension, leading to lipohyalinosis or microatheroma, rather than embolism. Classic lacunar syndromes include pure motor hemiparesis, affecting the internal capsule or pons, pure sensory stroke, thalamus, ataxic hemiparesis, pons, or internal capsule, dysarthria, clumsy hand syndrome, pons, and sensorimotor stroke, involving both thalamus and internal capsule. A useful memory rule is that lacunes are small, deep, and hypertensive, and they produce no cortical signs, meaning no aphasia, neglect, or visual field cut. Brainstem lesions produce distinct cranial nerve findings depending on the level of involvement. A CN3 lesion causes the eye to be down and out ipsilaterally. A complete lesion also includes ptosis, mydriasis, and diplopia. A CN4 lesion leads to inability to look down and a head tilt. A CNV lesion results in ipsilateral loss of pain and temperature on the face. A CN6 lesion causes ipsilateral weakness of abduction. A CN7 lesion produces ipsilateral facial weakness, loss of taste on the anterior 2/3 of the tongue, and hyperacusis. CN8 is located in the medulla and pons. Its lesion causes ipsilateral deafness, vertigo, vomiting, and nystagmus. A CN9 lesion leads to ipsilateral weakness of swallowing and ipsilateral loss of taste on the posterior 1/3 of the tongue. A CNX lesion causes ipsilateral loss of the gag reflex, ipsilateral palatal weakness, and uvula deviation away from the lesion. A CN11 lesion results in ipsilateral weakness with head rotation and shoulder elevation. A CN12 lesion produces ipsilateral weakness of the tongue, with the tongue deviating toward the lesion. The diagnosis and acute treatment of ischemic stroke. The initial diagnostic step involves identifying a focal neurologic deficit and performing a non-contrast CT scan along with blood tests. The CT scan distinguishes between ischemic stroke and hemorrhagic stroke. If the patient presents within 4.5 hours of symptom onset, the algorithm asks whether to give TPA. For patients who are not candidates for TPA, aspirin is given. In addition, risk assessment investigations are performed, including A1C, lipid profile, CBC, complete blood count, coagulation profile, PT, INR, APTT, and TSH. These tests are routinely performed in the emergency evaluation of suspected stroke to guide acute management, e.g., TPA eligibility, and to establish a comprehensive secondary prevention plan. Further diagnostic workup includes ECG, echo, and carotid ultrasound. If the ECG identifies atrial fibrillation/flutter, which is treated with warfarin or a NOAC without a heparin bridge. If echocardiogram shouts clot positive, treatment with anticoagulation. If carotid ultrasound shows greater than 80% stenosis or greater than 70% with symptoms, the patient treats medically selective surgeries such as carotid endarterectomy or stent will be performed. Acute and chronic management. In the acute setting, TPA is given for ischemic stroke within 3 hours if the patient has diabetes mellitus, or within 4 to 5 hours if the patient does not have diabetes. TPA is contraindicated in the presence of intracranial hemorrhage, active bleeding, recent surgery, or trauma. Heparin is not used. Antiplatelet drugs are required. Aspirin 325 milligrams must be given if the patient did not receive TPA. Blood pressure management follows a permissive hypertension strategy. For ischemic stroke without TPA, the target is less than 220/110 mmHg. For ischemic stroke with TPA, the target is less than 180/105 mmHg. For hemorrhagic stroke, the target is less than 150 to 80 mmHg. Diabetes mellitus is managed by controlling blood sugar, though not very strictly. No specific targets are noted for statin therapy or anticoagulation during acute stroke management. In the chronic setting, TPA is not typically used. Heparin is given only if there is a risk of deep vein thrombosis, using prophylactic low-dose LNWH, which also reduces the risk of cerebrovascular accident, CVA. Antiplatelet drugs are used as follows. For a first stroke, low-dose aspirin is given. For a repeat stroke, the regimen is aspirin plus dipyridamole. If that is not tolerated, clopidogrel monotherapy is used. In cases of aspirin allergy, clopidogrel is given. A short-term course of dual antiplatelet therapy, DAPT, with aspirin plus clopidogrel is recommended as initial treatment for patients with minor ischemic stroke or high-risk TI. However, aspirin and clopidogrel should not be combined long-term. Blood pressure is controlled with an ACE inhibitor and diuretics. For diabetes mellitus, the The target HbA1c is less than 7%. High-potency statins are used, specifically atorvastatin 40 mg or 80 mg. Anticoagulation is indicated for atrial fibrillation with a CHAD score of 2 or greater, in which case warfarin or a NOAC is started. Patients are also advised to quit smoking. Thrombolysis criteria. Inclusion for thrombolysis requires onset of ischemic stroke within the preceding 4.5 hours, though an extended window up to 9 hours, or for wake-up strokes, may be considered for select patients using advanced imaging. Tenecteplase is now a first-line alternative to alteplase, often preferred due to its simpler, single bolus administration. The patient should have a potentially disabling neurological deficit. Thrombolysis is generally not recommended for those with non-disabling deficits, in whom dual antiplatelet therapy, DAPT, is preferred. A CT scan must show no hemorrhage or non-vascular cause of stroke. Absolute contraindications. Thrombolysis should not be administered. Include uncertainty about time of stroke onset if the patient was last seen well more than 4.5 hours ago. Coagulopathy defined as INR greater than 1.5, platelet count 100,000/L, heparin with a raised APTT, or recent anticoagulant use. Suspicion of subarachnoid hemorrhage with vasospasm, suspected septic embolus, hypoglycemia, BGL less than or equal to 2.8 millimoles per liter, or hyperglycemia, BGL greater than or equal to 22.2. Hypertension with systolic greater than or equal to 185 millimeters of mercury, or diastolic greater than 110 millimeters of mercury, despite treatment, and seizure at onset without vessel occlusion or CT perfusion abnormality. Relative contraindications, used with caution, include severe neurological impairment, e.g., NIHSS greater than 22, coma, or severe obtundation. Those severe deficits are no longer a reason to withhold treatment if the patient is within the therapeutic window and otherwise eligible. Intravenous alteplase may be considered for children aged 28 days to 18 years with disabling ischemic stroke. Pregnancy remains a relative caution. Extensive MCA infarction on CT or large core infarction is no longer a strict exclusion. Stroke or serious head trauma within the past 3 months with high bleeding risk is a relative contraindication, and direct oral anticoagulants, DOACs, are no longer an absolute contraindication. TPA, thrombolytic, contraindications, and post-infusion precautions. Absolute contraindications for TPA administration include intracranial hemorrhage, prior intracranial hemorrhage, refractory hypertension with a blood pressure reading consistently greater than 185/110 mmHg despite treatment, active internal bleeding, hypoglycemia, which must be treated before proceeding, a history of bleeding disorders, and a platelet count below 100,000. Regarding anticoagulant use, TPA is contraindicated in patients with an INR greater than 1.7, PT greater than 15 seconds, or PTT greater than 40 seconds, as well as in those who have taken a direct oral anticoagulant, DOAC, within the last 48 hours. Relative contraindications, used with caution, include serious head trauma or stroke within the last 3 months, recent intracranial or intraspinal surgery, arterial puncture at a non-compressible site, minor or rapidly improving symptoms, a history of gastrointestinal or genitourinary bleeding, seizure at stroke onset, pregnancy, and recent myocardial infarction. Key points to remember after TPA infusion: no anticoagulants or antiplatelets, blood thinners, should be given for at least 24 hours. The patient must remain on bleeding precautions for at least 24 hours. Additionally, no invasive procedures should be performed for at least 24 hours after TPA infusion, including intramuscular injections, intravenous lines, nasogastric tubes, Foley catheters, and central lines.